broadcasting live from Houston, from the space city to the world. You are watching NowMedia Television.
Welcome everyone to NowMedia's premier medical show, Pain Diaries. I'm Dr. Suzanne Manzi and I welcome you. In today's episode, we have a few special guests. First, I'm grateful to have one of my patients here, Mr. Paul Daron. He has a pain relieving system implanted in his body and he's going to share his entire story with us. I'll also be featuring Dr. Tammy Dann from Dayton, Ohio, one of my good friends and colleagues who also specializes in interventional pain management. Remember, you can find me, Dr. Suzanne Manzi, at Performance Pain and Sports Medicine. Our website is www.performancepain.com, or you can reach us by phone, 346-217-1111. I have two locations, 4126 Southwest Freeway, Suite 1700 in Houston, Texas, 77027 in the penthouse of the T-Mobile Tower, next to Greenway Plaza. Also in League City, Texas, officing out of League City Spine and Sports at 1200 East Main Street. And don't forget, tune into Pain Diaries on the following channels: Houston, 2110, Beaumont, 2710, Atlanta, 2210, Lake Charles, 2110, College Station, 1410, Eagle Pass, 24, Piedras Negras, 24. And hear us in Chicago on 102.9 FM and 104.3 FM in Huntsville, Texas. Don't forget to tune into Spotify, Apple Podcast, and Amazon Music. And follow us on all our social media and digital platforms such as NowMedia.com. Please note, the information in this show is for informational purposes only and is not medical advice. It is not a substitute for professional medical advice, and I urge you to seek medical advice from your physician regarding any medical condition. Reliance on the information provided in this show is provided solely at your own risk. Hello, I'm Dr. Suzanne Manzi, and this is Pain Diaries. Dr. Suzanne Manzi with Performance Pain and Sports Medicine here in Houston, Texas. I welcome you back to Pain Diaries on NowMedia Television. Medical technology is one of my passions, and innovative devices allow us at Performance Pain and Sports Medicine to change lives. I'd like to introduce Medtronic's intrathecal drug delivery system. This is also known as an intrathecal pump. You're probably wondering, what does the word intrathecal mean? The intrathecal space describes the fluid-filled space between the layers of tissue that cover the brain and the spinal cord. So drugs can be injected into this fluid, or a sample of the fluid can be removed for testing. For example, a spinal tap. That's the fluid that's drawn off. So first, Medtronic is one of the leaders in the pain space. They're a company that manufactures medical devices. The Medtronic mission is to contribute to human welfare by application of biomedical engineering in research, design, manufacture, and sale of instruments or appliances that alleviate pain, restore health, and extend life. In today's episode, I'll be talking about one of their instruments that alleviates pain through targeted drug delivery. And thus, I want to introduce you to their intrathecal pump. This is the pump here. So I'm going to show you some videos about this and give you more educational information regarding a pump. So some people refer to this device as a pain pump or just a pump because some people utilize this with more than just one pain medication. A bit more about medications later when we talk to Dr. Dann. So let's take a look at the pump. Synchromed 2 pump is the name of Medtronic's current pump system. They're offered in two different sizes. Here we have a 20 milliliter size. It also comes in a 40 milliliter size, which is a little bit thicker than this one. These allow the space to create efficient refill intervals. So patients don't have to come back every month. They can last 3, 4, 5 months, or even longer. This pump also allows a powerful, long-lasting durability with diamond-like carbon coating that resists the wear from gear revolutions. You can see it's very sturdy. It's designed to last up to 7 years, and each pump precisely delivers a reliable and consistent amount of drug. It allows for safe, full-body access to 1.5 and 3.0 Tesla MRI. That's important that it has such good MRI compatibility when patients are sick and need to have body scans. The pump is designed to resume programming therapy after the scan and does not need to be emptied prior to a scan, and this minimizes drug waste and procedural steps, as well as patient safety. So let's play the patient introductory video for a more detailed education about this system.
See important safety information at the end of the video. Only your doctor can determine if this therapy is right for you. Think about it. You don't need an axe to crack a nut. You don't use a blowtorch to light a candle. And constant pain shouldn't be treated with piles of pills. Most people take pills for pain, and it takes a lot of pills when you're in a lot of pain. Pills must travel through the stomach and intestines. Then the medicine travels through the bloodstream before finally arriving at the site where it works. Oh, the side effects of all that medicine. It often takes more pills to treat these. And the stigma around taking all of those drugs is scary. Well, engineers at Medtronic invented a smarter way to control chronic pain. It's called targeted drug delivery, and it has been available for some time. A pump is implanted just under the skin. Tiny doses of pain medicine travel from the pump through a thin, flexible tube to the fluid surrounding the spinal cord. The right amount of medicine goes to the precise spot it's needed to most effectively treat the pain. Voila! Targeted drug delivery gives you pain relief with a fraction of the amount of medicine. And because there's no longer a giant amount of medicine floating through the body, targeted drug delivery has fewer side effects compared to taking many pain pills. More good news. Many patients using targeted drug delivery no longer need any pain pills or need much less. Ask your doctor about a targeted drug delivery trial to see if this pain therapy is right for you. It's like taking a test drive before deciding. If you decide to move forward after the trial, you'll get scheduled to implant your pump, which is usually an outpatient procedure that takes about an hour. Once you have your pump, here's how it works. Your doctor programs the SynchroMed 2 pump to deliver the exact amount of medicine you need. The pump is typically refilled every few months. This means fewer doctor appointments to request drug refills and fewer trips to the pharmacy. More time for you to do the things you enjoy. Discover more about Medtronic targeted drug delivery at medtronic.com/painpump. Get ready to say goodbye to piles of pills and miserable side effects, and hello to doing more things you love. Important safety information. The SynchroMed 2 infusion system delivers pain medication directly to the fluid around the spinal cord for the long-term treatment of chronic pain, such as cancer pain, back or leg pain, complex regional pain syndrome, and painful neuropathy. Targeted drug delivery should be considered after you have tried oral medications or other therapies and they have not worked or you cannot tolerate them. Pump or catheter problems can occur after implantation, which may require corrective surgery and/or cause a drug overdose or underdose that may be serious or life-threatening. Implanting the system has risks similar to any surgical procedure, including infection. Drugs infused through the system may result in adverse effects. Errors in locating the pump during the refill procedure can result in symptoms of overdose that may be serious or life-threatening. Not everyone responds to targeted drug delivery in the same way, and your experience may vary. To understand the benefits and risks of targeted drug delivery, please discuss them in detail with your physician. A prescription is required. For complete safety information about Medtronic targeted drug delivery therapy, call Medtronic at 800-328-0810 or visit Medtronic's website.
I hope you found that video informative. The opportunities are endless in helping change people's lives who are suffering, and the intrathecal pump is one of the modalities we utilize at Performance Pain and Sports Medicine in hopes of relieving suffering and improving function. Stay tuned for more to come. I'm Dr. Suzanne Manzi here on NowMedia TV in Houston, Texas, and this is Pain Diaries. We'll be right back after a commercial break. Welcome back to Pain Diaries. I'm here, Dr. Suzanne Manzi with Performance Pain and Sports Medicine, and I'm excited to introduce Mr. Paul Daron.
Howdy.
He has been my patient for almost 10 years. Thank you so much for taking the time today to come and share your story on today's episode of Pain Diaries.
Absolutely. Thanks for having me.
So let's start a little bit about yourself.
Okay.
I know you're a husband, a dad, and you're full-time employed. And that's a lot, but you've had to suffer from chronic pain after a work injury in 2018. You've had surgeries, you've had injections, and you used to be on high-dose medications.
I was.
So can you tell us a little bit about your story and how it all started and where you've ended up now?
So sure, absolutely. So it actually started in 2008. The pump came later. So,
Right.
But I was on a very high dose pain pills, pain medication. Basically, just became a slave to the pain meds for a very, very long time. And it impacted the way you went to work, it impacted the way you raise your family, it impacted everything.
Yeah.
So for me, the pain pump has been nothing short of a miracle.
Oh, that's amazing. I know when I was seeing you back in 2013 and 2014, you came to me on high-dose opioids, and I would have to see you every month because of the way the laws are. You know, that regimen was actually kind of keeping you functional,
Right.
but it wasn't enough. But it was enough to get you to go to work, and enough to
Right.
interact with your family, and enough to keep you going. And I didn't necessarily want to write those meds the way you came to me on them.
Right.
But I had to keep you in work, and I had to keep you functional. And we
For
talked
sure.
about other options, and we did interventional procedures, you know, epidural steroid injections for your back and
Yep.
things like that, and your chronic nerve pain. But there was just not enough. And, you know, I feel like because you don't necessarily look like a chronic pain patient, you know, what does chronic pain look like, right? You just, to me, look like a regular guy. You have a family, you're happy-go-lucky, you're always in a good mood when you come to the office, and you're coming from work, and you just need to go back to work,
Right.
usually when you see me. And so I feel like you were a great person to showcase that chronic pain comes in all different forms, and you've made it through the whole crazy opioid scare. With the doses you were on, I mean, if I took that, I would die.
Right.
I would stop breathing. But we were able to get you off and transition you to an intrathecal pain pump for your chronic pain. So can you talk about maybe the side effects that you had with the pain meds versus the side effects you have now with the actual medication that's in the pump that goes directly into your spine?
Yeah, sure. So it's absolutely night and day. So when I was on pain meds, I was, you know, I couldn't leave the house without having a pocket rattling with pain meds in them.
Mm-hmm.
Wake up every day with a hangover, just tough to get going. You basically felt the best at the end of the night. And every day it was just a cycle of just trying to get through, keep your family fed, and make it to work, and do everything you have to do. And since I've been on the pain pump, it's like I have no pain meds in me at all. Like there's nothing in my head. There's no hangover every day. There's no fogginess. Yeah, it's really been life-changing. And I don't fidget when I sit like I used to. Like, that's one way you can tell when someone is on chronic pain, no matter how they dress, no matter how they show up to work, is they're getting up, they're fidgety all the time.
Right.
And it's just gotten rid of all that.
Yeah, that's amazing, because your injury is 2008. We didn't put the pump in until 2018. Now, when you first started seeing me, the pump world was very different. People would put medicine in and then they would crank it up. Now, that's still an acceptable way to do it, especially for people with like chronic cancer pain or end of life type comfort level pain. But people we know that have had spine surgery or just, back pain, and they do require high dose opioids for long term, and they now are transitioned to a pump, we use something called microdosing. And microdosing is using a lower dose of the pain medications, but it's still high dose because it's delivered into the spinal fluid. But you don't get those terrible feelings of hangover or fogginess or dizziness or drowsiness or irritability. And you were married to me. You had to see me every month. I mean, and if you miss that appointment, what happens,
man.
Right?
I had to rearrange schedules. I
Right.
mean, everything. Like, you couldn't take a vacation.
Exactly.
Everything was dedicated to making sure I didn't do anything to disrupt my delivery of pain meds.
Exactly. So now I see you once every 4 months.
Right.
And it literally takes
I miss you, but it's good.
it takes 5 minutes to fill the pump. Now, what's nice is, our office, we do it safely, and most offices should refill these safely. But it's like, here's the pump, and your pump is on the side, right in the front of your belly, and this little port here is what we use. So we know the pump's under your skin there, and I take an ultrasound and I scan him, and I see where it's inserted, where the hole is, and then I pop a needle right through your skin. I take out the old medicine and I put the new medicine back in. We confirm it's your medicine. It comes from a compounding pharmacy, and your pump is filled with morphine, and that's just a standard drug we put in one of the pumps. There's other drugs we can put in, but you're doing great with morphine. You've always done great with it, and so we'll keep what's working. Right. Why change something that doesn't need changing? So what's nice is, he has a 20 cc pump. It's not too big.
Nope,
it
small.
doesn't bother you.
Don't even know it's there.
Then that's great. And it's under your skin. It's easily accessible. It has a battery life of about 7 years. So we'll have to change it at some point.
Right.
But we just kind of open up the pocket, take out the old one, rehook up the catheter. This little portion here has a tube that wraps around and goes up into your spine. And so that's delivering the medicines right into your spinal fluid. And so that should, last 7 years. We'll get a new one in there when we need to. And then you're good to go again for 7 years. And then I only have to see you quarterly, basically, based on the dose you're on right now. And it's fully adjustable, which is really, it's titrated to what you need. It's individual therapy for you.
Do you think I could have fit 7 months of pain pills? Or 3 months of pain pills in here?
Definitely not. You were on mass quantities of pain medicine. I'm so grateful that you were off and you believed in me and us at Performance Pain and Sports Medicine. You're in my 3rd practice now. I think I met you when I was over at UT at Tier, and then you transitioned to my first private practice over in Bel Air, and now at Performance Pain and Sports Medicine with my partner, Dr. Wiederholtz, and I. And Mr. Daron's been great. I mean, he would do anything to be out of pain, and now we found a solution for him, and it really has changed his life.
It has.
So
thank you.
Thank you.
My family thanks you.
I'm glad you can now go on vacation with your family, be comfortable, when you were watching your son play sports as he grew up. That's really amazing stuff.
It is.
So life-changing therapy here with Medtronic's SynchroMed pump. thank you, Mr. Daring, taking the time to share your story with the world. We really appreciate you here on Pain Diaries.
No problem.
And
thank you.
At Performance Pain and Sports Medicine. So, if you know somebody in chronic pain, please reach out to see if they are a candidate for intrathecal drug delivery and see if it's right for them. Because at Performance Pain and Sports Medicine, we change lives. We make lives live for the better. And I'm Dr. Suzanne Manzi, and this is Pain Diaries. We will return after commercial break.
Awesome.
Thank you.
Thank you.
Welcome back to NowMedia's TV show, Pain Diaries, broadcasting here in Houston, Texas on channel 2110. We are back with Dr. Tammy Dann. I am pleased to introduce her and welcome her to the show. Dr. Dann, since today's episode is all about intrathecal pain pumps, we are looking forward to hearing all about your expertise. First, can you tell us a little bit about your practice? Where do you practice and what you do and why you do it?
Well, thanks for having me, first of all, today. I'm really excited to talk about pump therapy as it's one of my passions. I am located in Dayton, Ohio, and I have a private practice that has about 3 physicians and 5 nurse practitioners in it. And we manage about 350 to 400 pumps at this time. Wow. And I have an anesthesia background, and then I also have pain management as well. So, we look at things a little bit differently than each other, but in the end, the patients all get very good benefit from this therapy.
That's awesome. So I know you love pain management and you love what you do, but why do you like to manage patients' pain with intrathecal pumps in particular?
So pumps hold a place near and dear in my heart, partly because you get to know these patients really good. Like you were saying, you were kind of married to Mr. Daron earlier with his pain pills. Most of these patients have been on pain pills for quite a long time over their period of time. I would say on average, most of my patients come and they've had chronic pain for at least 10 to 20 years by the time they get to my office. So a lot of times they've been taking those pain pills for that same amount of time. Now, when we see them and I can offer them something that no one else has been able to offer them, then they like to jump right on it. And they say, hey, this is something minimally invasive. It's something that I can try out first, because we do a trial first before we put the pump in to see if they tolerate the medicine, if it works well for them. So we have a lot of opportunity with these patients that they never had before. So we can suddenly treat their pain with something that is actually much more effective, gives them far less side effect, and they're very happy with it. Like your patient was saying earlier, now they can go on vacation. They aren't tied to the pharmacy, going to your office every single month. God forbid there be bad weather and they miss an appointment and they have to somehow get their medications. They don't have to worry about that stuff as much. So these patients actually do quite well.
Yeah, I've definitely seen that in my practice too. What kind of pains do you usually manage or treat patients with? What kind of diagnoses do they have when you utilize an intrathecal pump for therapy?
So I think what we're taught when we're in our pain fellowships is that these are patients that have chronic, what we call axial or midline low back pain. So that's what I started out doing. You figure out over time, however, that patients with all kinds of pain problems do very, very well from this modality. So scoliosis, degenerative disc disease, failed back surgery. As you mentioned earlier, the cancer pain patients are very classically what we think of for this, but it really reaches far and wide. I have some more patients that have complex regional pain syndrome, people with trigeminal neuralgia. You really can go far and wide with casting your net on the types of patients and the types of pain that this treats. And like I said earlier, the beauty of this is that you can always test it out first and see if it's going to help prior to putting in the pump.
Absolutely. I feel like, especially like you said, the axial low back pain, when they've had surgeries and whatnot, and other types of procedures to their back, and nothing just really gives them that relief. I feel like those are pretty much slam dunks when you can get that catheter up to that T10 level and really stimulate that area with that targeted drug delivery right there. They do so well. What kind of complications have you seen in this type of treatment?
What was that again?
What type of complications have you had in this type of treatment with pumps? Have you had any issues with placing them, or after the patients have them, have you had any significant complications that the patients have suffered from having a pump?
So in my experience, the main things that we look out for are infection and bleeding. Anytime you cut any tissue with a scalpel to do any sort of procedure, you're always going to have that risk of infection and bleeding. And those are going to be the two most common complications that you can see with this procedure. Infection, of course, is going to be more likely in people that smoke, have poorly controlled diabetes. So we try to control for those factors before we put the pump in, if at all possible. Now, as far as bleeding risk goes, people that are on chronic blood thinners already, we usually work very closely with their primary care physicians and the cardiology department or neurology department, whoever's prescribing these medicines, and we try to make sure that people safely can come off of them for the procedure. And if they cannot come off of them, then a lot of times we do have to look for something different that can be done for them. But those are kind of the two primary issues that you would see with this procedure and are going to be the most common ones. Now, there are risks that are much higher as far as, paralysis, things like that. You're going to read about that on the internet. That is so rare because people actually are well prepared at this point in time. It would be very odd to see that, and I personally have never seen anything like that in my practice.
Oh, absolutely. Yeah, we haven't had any kind of paralysis or anything like that. I know patients, especially that have diabetes, they're more prone to infection, and we try to make sure, if we are going to implant any type of high-level device in them, that their blood sugar is somewhat controlled before we do so, because we want them to succeed. We don't want them to have to suffer from any kind of infection or have to take antibiotics for the rest of their life or anything like that.
Exactly, completely. That's what we do as well. And I think that's going to be commonplace across the United States. The pain doctors of nowadays, we tend to work a lot more collaboratively with our other specialists and primary cares, I feel like.
Absolutely. Yeah, I have a new endocrinologist in our building, and I'm like, oh, great. I can refer the diabetic patients to hopefully get faster treatment than having to wait 6 months, which is usually the wait to get in. So that way we can do these treatments on them and help alleviate their pain to get those blood sugars under better control. The last thing we want is any kind of infection, because the catheter goes into the spinal canal, and so we definitely don't want any kind of infection to happen in these kind of devices, but it is very, very rare. And so obviously with any pain procedure, I tell patients there's risk of pain, bleeding, infection, but we do everything under a very safe OR environment in a sterile fashion and make sure it's as safe as possible for patients so they get the best outcome. And this is why we're in medicine, and with pumps, I feel like we can really change lives to help their pain, get them more functional. So the last thing is we want is a complication out of it.
Exactly.
So what, I know with Mr. Daron, I see him every 4 months or so for refills. What kind of follow-up do you usually have after they have the pump placed initially and then thereafter?
So classically, and I'll kind of back it up just a little bit, before we put the pump in the patient, we usually have a very defined taper schedule for the patient. So we're checking in with them monthly, trying to taper down their medications. And I do usually taper them down to some degree before we put the pump in, preferably off at least for a few days. But they're going to meet with their primary care provider. They're going to meet with our Medtronic representative to kind of explain what this pump is, what the programming looks like for it, what their personal therapy manager looks like. It will kind of go through all of that with them, making sure that people are very well in tune with what's going to happen with them. After the pump is put in, we will see them back in the office at 7 days post-operatively so that we can take down the bandages and program the pump at that time. After that, we will see them at 4 weeks post-operatively to evaluate the wound once again, see if there's any tweaks that need to be done with the pump itself. And then following that, it just kind of depends on how much they're using the pump. We would say usually it's going to be an 8-week follow-up after that. And then once we make sure that everything is healed up and that the pump is working to the degree that they'd like it to be working, they classically come back to see us about every 3 to 4 months for that pump refill. If for some reason someone is nursing homebound or they have extreme difficulty getting into the office, they have no transportation, sometimes we can make exceptions and be able to stretch that medicine out to 6 months, even if we absolutely needed to. So there is a lot of flexibility with this. It makes it so the patient, it doesn't feel like they are tied to us all the time. I've had patients say, I get to see you more than I get to see like my son or my daughter or someone like that. So they say, you almost feel like family because I see you every single month. But I don't want them to make me to feel like I'm their family. I want them to go home and spend time with their own family. And this actually gives them that opportunity to be able to do that.
Absolutely. I love the flexibility too. I mean, like Mr. Daron said, I mean, he's not married to me anymore. I see him every 4 months. And yeah, some people that have transportation issues or they're just, frail and elderly, and, sometimes we stretch it out to 6 months if we need to. They can't make it in, but at least we have the flexibility. And there's different ways with the flexibility, whether it be, different medications or different programming settings that we have, that the medication's delivered differently. You can time when the medication's given. It can be given as a bolus. It can be given continuous. We call flex dosing, more in the evening or more during the day. It just depends on what the patient needs. And it's so tailored to every single patient. And that's where us as the doctors come in, and we have to listen to the patient. What kind of pain do they have? What kind of medicine do they need? How are we going to program the pump? Those kind of things. It's so important that, we tailor the therapy for the patient, particularly for what they need to keep them functional. Do your patients usually like their pumps?
This is life-changing for these patients.
Yeah, it is. So they must like it if they think it's life-changing, right?
Exactly. I get lots of good Christmas presents from my patients that have pumps, actually. They are very, very appreciative. I've gotten baby blankets, Christmas ornaments that have been made, handmade Christmas cards, all kinds of fun stuff.
That's awesome. What kind of medicine do you usually use in the pumps?
So there are actually 3 FDA-approved medications to use in the pump, and that's what we normally try to stick to. As you mentioned earlier with Mr. Daron, there is morphine that we utilize, and that's probably the biggest medication that we utilize in the pump. There's also something called ziconotide, that's cone snail venom. It sounds very high tech. It's a non-narcotic pain medication, and it only works in the intrathecal space. So this is a perfect delivery method for that type of medication for people that don't want to be on an opioid. As far as the third medication, that is baclofen, which is a spasticity medication, which you're probably far more familiar with having your PMR background than I am with anesthesia background. But we do use that actually for quite a few patients that have spasticity issues as well as pain issues, like there have been spinal cord injuries or they have multiple sclerosis, things like that. So those are going to be the 3 primary medications. There are some other medications that we use as well, including a local anesthetic medication called bupivacaine that you can put in, especially when people are trying to conserve how much of the narcotic that they're using and they're not comfortable with using a higher dose. Then a lot of times we can add that. There's also another medication called clonidine that can be added in as well. So we have lots of different options. As far as the actual pain medications themselves go, you've got the morphine that we primarily use. You can also utilize Dilaudid in instances of allergy, things that people, say, I've had a bad experience with morphine in the past and really don't want to try it out again. You can utilize the Dilaudid. You can utilize fentanyl, sufentanil. We've got lots of options. I don't really need to go much beyond those 3, though, that I mentioned most of the time. It would be quite a rare instance that we really are needing to move on to some of those other medications in general. And I have people that, say, I don't want any narcotics in mine at all. That's fine. We have lots of options for those patients. Like I said, between the ziconotide, which is also called Prialt, as well as the bupivacaine and the clonidine.
Thank you. Yeah, I feel the same. We practice very similarly, and that's exactly what we do with our pump patients as well here in Houston. I'm glad it's consistent for the most part for us microdosers across the states. So
yeah, we're really trying to conserve the amount of opioid that we're utilizing, if at all possible. It really does work better when you use those microdosing. And also it helps when you have a compounding pharmacy that you can utilize that's very well respected, like we all have access to at this point.
Absolutely. Anything else you'd like to add before we conclude?
I think that's it. I just, am trying to get the word out that, this is a great therapy, and it's really been a game changer for a lot of patients that have had chronic pain for a long time. And, if you've never heard of this therapy before, or it's something that you're interested in, please find someone that can tell you more about it and can get you plugged into the right outlets in order to find the physicians that are going to help you with this therapy.
Absolutely. Thank you so much, Dr. Dann. We greatly appreciate you being on today's show. And like she said, if you or a loved one is suffering, please know there are options. Find the nearest pain expert in the field to see if you are a candidate for amazing medical technologies like the intrathecal pump, which can change lives for the better. This is Pain Diaries, and we'll be back after a commercial break. I'm Dr. Suzanne Manzi. Take care of you so you can take care of business. See you in a few minutes. NowMedia TV and Pain Diaries welcomes Craig Murphy back to the show. We have some questions from the audience from our previous interview, and we would love to explore a little more regarding some of our insurance options when it comes to employers. So Craig, now there was a little confusion about what constitutes a group.
Sure.
How many employees do you have to even get on a group insurance plan?
So it's pretty simple. It's actually 2 employees. The difference is that some insurance companies are going to be a little bit hesitant if the 2 employees are husband and wife, but some others are perfectly okay with that. So if you are looking for a group policy, which offers you a much wider range of benefit options as opposed to an individual plan, definitely talk to us. We'd be happy to show you some of the options that are available as a group policy as opposed to an individual policy.
Okay, that's great. And then I guess the other question that came in, some people are actually employed, they're W-2s versus
Right.
1099 where you're contracted.
Right.
Is there a difference from when you're an employer providing insurance coverage for these different types of classifications when it comes to employing people?
And again, that is, most insurance companies are going to have a problem if all of the employees are 1099s, but there are some companies, if some portion of your group are 1099s and they are exclusively working for you, they're not working for anyone else, then sometimes they will, again, agree to that. It's not every single carrier, but there are enough options out there to be considered for that. You do need at least one W-2 person and the ability to show the payroll that these people are working for you on a regular basis, not just seasonally or temporarily.
So if they're only working, let's say like the summer season's busy or something, it wouldn't actually work?
It's generally no, because what the insurance companies want that long relationship, and so you're not going to be able to have just people who are going to be there for a couple of months and then drop back off. They're looking for someone who's probably theoretically is going to be around for an entire year at a time.
But that's still great news to hear, because a 1099 employee might not be able to afford their own insurance. And if they're contracted on a regular basis,
right,
they can potentially qualify.
That's correct. Keep in mind that the employer, there has to be that employer-employee relationship, and the employer has to be willing to contribute at least 50% of the cost of that of the cheapest plan that they're offering. They can offer multiple plans, but the cheapest plan they have to pay a minimum of 50%. So it's not, there is some skin in the game for the employer as well as the employee. And generally speaking, if you're trying to get an adequate number of people to participate, the employer has to contribute maybe even more than half the cost to encourage some of the, the range of employees, the critical
Right.
number to participate.
Okay, well, that's great to know. I never knew that was an option.
Right. Well, that's one of the things that you can, if you talk to somebody. There are just a lot of people who kind of go into insurance with some preconceived notions that are not always correct.
Absolutely. And then, again, that's why we're here on Pain Diaries talking insurance, because it's a painful subject for so many people.
Sure.
And it creates headaches, and it creates turmoil, and it creates stress. And my job, being host of Pain Diaries, is to hopefully alleviate people's stress in educating them about what's available in the medical world.
Sure. Well, that's perfectly makes sense, and it's if you have to pay for doctor visits out of your pocket, it can be very painful, and
For sure.
And it's not insignificant, the amount of money that you're paying for health insurance, but it particularly can help if you have ongoing conditions. You need insurance if you're going to need to go to the doctor on a regular basis.
And even, I always tell patients, if they don't have any insurance, you really should look at even getting some kind of basic coverage for a catastrophic. You don't know what can happen, especially driving in Houston. It's
Absolutely.
reckless out there.
And it's amazing. On an individual, even though I don't work in individual coverage, there are tremendous options available, and with the subsidies available on individual coverage, it's really a shame when people think that they can't have coverage because it's available out there. It may not be it may not be covering first dollar coverage, but at least if you wind up in the hospital with you need your appendix out,
Right.
Believe me, talk about Pain Diaries. That would be a very painful experience if you're having to pay out of your own pocket for that.
Exactly.
For years to come.
So another question from the audience: can you describe more about the difference? When you're subscribing an employer,
Right.
do you offer different PPOs versus HMOs for the company, or does it matter how many employees you have to offer a PPO? Things like that?
No, not at all. And in
Okay.
fact, we've got small groups that are as small as 2 employees, and you can offer both PPOs as well as HMOs. You can even offer, in many carriers, a combination of plans. So you could offer an HMO and a PPO.
Okay. Can you describe which one is which? Because that's
Sure.
super confusing for so many people.
Sure. An HMO HMOs get a bad rap, but they're really excellent insurance, and it provides some great benefits. The big difference is in the network, as well as and generally speaking, an HMO stands for Health Maintenance Organization,
Mm-hmm.
and an HMO generally has a smaller network than a PPO. The doctors, you would normally have to choose a primary care physician who would be a doctor who's in the network, and this would normally be a doctor of internal medicine,
Mm-hmm.
a family practitioner, a general practitioner, or a pediatrician. For females, you could sometimes go to an OBGYN. That would be your primary doctor, and if you needed care, you would go to that doctor first, and if you needed to go ultimately maybe to see a specialist, you would have to go to that primary care physician first, and they would have to give you a referral. So for some people, that's kind of onerous. It's kind of a bother to have to go to one doctor when they think they need to go to another doctor. It's the goal of the primary care physician to basically do whatever they can to take care of those conditions on their own, rather than immediately going to a much more costly specialist.
Right. I have patients that come to me and they have HMOs,
Right.
but I have to have a referral on file.
Generally speaking, there are
Usually.
there are exceptions these days.
Of course.
There's what are called open access HMOs. We're not going to get into that, but generally it's a smaller network of doctors. You're going to have to go through that step, and it's generally in exchange for that you're going to pay a lower premium, and you're going to generally, unless it's a high deductible plan, you'll normally have copays affiliated with doctor visits, for example. So it's a good plan. It's especially if you're young and pretty healthy, they work really well. If you've got a whole host of chronic conditions and you need to see 5 doctors a year, it is going to be very time consuming for you to go bouncing back and forth between the primary care physician and your specialist when you think you really already know who you need to go see. So
Absolutely.
PPOs, generally speaking, much larger networks. They're generally a national network of doctors. So if you wanted to go to the Mayo Clinic in Ohio, Minnesota, you could just go. So you've got a larger network of doctors. Generally, more doctors accept it, and it gives you the true open access. It generally also gives you what are called out-of-network benefits. That usually comes at a considerable cost in terms of deductibles and coinsurance, but it allows you to go to doctors that aren't even affiliated with the network of doctors.
Right.
So most of the major insurance carriers like Blue Cross, Humana, United, Aetna offer a variety of these plans, and it really makes sense for companies to offer a variety of plans depending on the health needs of their employees and the price point that is affordable to those employees.
Perfectly well said.
So yeah, that's why they exist, and it's they exist for a reason, and they're not for everybody, but they fulfill a niche that is very important.
Well, Craig Murphy, thank you for offering options to employers. We really appreciate you being here on Pain Diaries today.
Thank you.
Thank you. We look forward to seeing you again on the show here in Houston, Texas at 2110 on NowMedia TV and across all platforms. And also thank you to April Clark and Dana Oliva for being on the show today. This is Pain Diaries, and I am Dr. Suzanne Manzi. Remember, take care of you so you can take care of business.
Thank you.
This has been a NowMedia television feature presentation. All rights reserved.